either in whichever discipline, of hematology and discipline of medicine, because hematology laboratory tests are done for many, many diseases that you're going to study, right? I hope you can hear me. If there's any interruption, please let me know. In case there's some interruption in the network, please let me know. Okay, so the lecture objectives for this class today is that at the end of this class, you should be able to describe some of the descriptive terms that we use to evaluate red cell morphological changes, because these are terms that are used in everyday clinical practice, and you as the medical practitioner will be able to receive reports from the laboratory using these descriptive terms. And then the second objective is you should give examples of the red cell morphological changes and also be able to give examples of clinical conditions in which those morphological changes are found. The red cell morphological changes occur and may even define a disease, or even you may be able to make diagnoses of a disease by the morphological changes that occur of the red cell. A good example of a disease condition that you may know, like for example, a hematological disease, is sickle cell disease. And sickle cell disease in its homozygous is fairly simple to diagnose because the red cells acquire a morphological change that is easily seen under the microscope, and one may almost to 90%, 100% make a diagnosis of sickle cell disease based on a simple examination of a peripheral blood film, which I'm going to describe shortly. So, and then of course, the last objective is you should be able to describe the preparation and general aspects of peripheral blood film examination, because in describing red cell morphological changes, the laboratory test that we do is a peripheral blood film preparation and staining that is done by expert technologists, and we use different stains to stain the red cell. You've been introduced to this in physiology. And then we examine the peripheral blood under the microscope. This is, you're going to get a chance to probably even make a peripheral blood film, and this will be probably in your third year when you come for your clerkships in the lab. You'll be able to make a peripheral blood film. You'll be able to stain it. You'll be able to see the different staining methodologies and even go through the general principles of examination of the peripheral blood film. Okay, so those are the lecture objectives for this for the next 50 minutes or so. Okay, so this is just a revision of the human erythrocyte or red cell, right? This I presume you already know, introduced by my colleagues in the previous lectures. You know that the normal size of the red cell is just about 7.9 micrometers in diameter. It has a biconcave shape on a two-dimensional view, but we know that it's a complex cell, and it has this, it extrudes its nucleus so that it can optimize its function of oxygen transport. So most of the red cell is full of hemoglobin, and there is an area of central pallor, which on a dimension looks like like a pill area. But we know that in a 3-dimension, it's the biconcave shaped red cell that looks like a donut. The red cell has no inclusions because it extrudes, it's a unique cell among all the other somatic cells. It extrudes its nucleus, and you already been told that when it does this, it gives up the capacity to generate energy using the TCA cycle. So it gives up that the nucleus, because you need the nucleus for the TCA cycle to occur. So the red cell gives up that, and it's got no inclusions and it's got no nucleus. So if you, I don't know, I think you've seen this picture of the red cell. It looks like a really beautiful cell, like a donut with a biconcave shape. And remember, you've already done the structure of the red cell. You know that it is very flexible. It can change its shape in terms of ability to perfuse through very small vascular channels, and it can even go through a vascular channel, let's say a capillary, that is 10 to 20 times its size, by the fact that it has this flexible membrane, which has a special structure, which I hope has been handled in biochemistry or physiology, and previously in the lecture that you've had, red cell structure and changes, right? So if we look at a three-dimensional view, this is what it looks like. And if we look at a two-dimensional view, you have this area of central pala that that is pale. It's it's not hemoglobinized compared to the pinkish area. When you stain it, the pinkish area is what contains the hemoglobin. So usually the area of central pala on a two-dimensional peripheral blood film makes up a third of, or less than a third of the cell, the area of central pala. Okay, so this is not good micrograph of peripheral blood film. I've just taken a picture. The staining capacities are not very good, and when you take a picture, it doesn't usually come out very well, but you'll be able to see that we use stains that give you very good morphology of the red cell. And the dark cell here that I've put is a small mature lymphocyte, which is a normal, one of the normal white cells in peripheral blood. And the reason why I have put this small lymphocyte here is because when we are looking under the microscope, the small mature lymphocyte is almost the size of the red cell. So in describing sizes of the red cell under the microscope, the morphologist usually looks for a small mature lymphocyte. If the cells surrounding that small lymphocyte are similar size, then we say the red cells are normocytic, in that they are of normal size. And remember, using the hematology cell counters that you've been introduced to in the last, or that you will be introduced to the lab, but even using the red cell index, the parameter that you are introduced to, or the index that you are introduced to that measures red cell size, is the beta. And we know that the red cell has a normal size of 76 to 96. So the variation is quite wide, femtoliters. All right. And we call that a normocytic cell. It is of normal size. And then when we look at the red cell itself, and usually under the microscope, because we are not able to measure femtoliters with our eyes, we use the lymphocyte to compare with the red cells in the peripheral blood film, so that if they're the same size as the small mature lymphocyte, which we know is almost the same size with the red cell, we call the cells normocytic. All right. And then normochromic refers to the area of hemoglobinization, and we measure the area of hemoglobinization by looking at the area of central pala. And as I told you, in a normal red cell, the area of central pala is usually less than a third of less of the red cell diameter. So if you look at these cells, you can imagine the red, or you can see that the area of central pallor is almost less than a third, most of them less than a third of the red cell, and we call that normochromic. So then the term normochromic refers to the level of hemoglobinization of the red cell. Okay, so normal red cells are usually referred to as normocytic normochromic red cells, right? Okay, so I'd like to introduce the laboratory aspects of red cell morphological changes, all right? So last week, you went through the total blood count, and you went through the values and parameters of red cells that we use in clinical practice to describe or evaluate the red cell. And remember, the red cell values are values like hemoglobin content, which you are introduced to. The other value is hematocrit, for example, you can calculate using the various parameters of the red cell. Another red cell value, for example, is red mass, which we don't measure so much in the laboratory because it's an expensive test to do. And but we know we can use it to describe various disease conditions. So that's red cell mass. And then you have reticulocyte count introduced, and those are the red cell values. Then you have indices. So indices are used to describe red cell size and area of or degree of hemoglobinization, for example, the mean cell hemoglobin. And then we have the mean cell hemoglobin concentration. And you were told that there are various formulae that we use to derive these indices, and some of them can be measured automated by the automated cell counters that we have in the laboratory. You'll have a chance to see this when you're doing your clerkship in third year, or you'll be introduced to them in second year, all right? So we have total blood counts, and then we have the peripheral blood film that we use to now describe this morphological changes that the red cell may take, and we are able to see them under the microscope on a stained peripheral blood film, all right? And we know that total blood counts and peripheral blood film comprise a lot of the laboratory tests that are requested by clinicians. So when you become a clinician in whichever specialty that you'll be in, whether you're in surgery, whether you're in obstetrics or pediatrics, you will be requesting the laboratory to do for you total blood counts and peripheral blood films as evaluation of your patient's diseases. So the hematology laboratory is a very busy laboratory. We receive quite a number of these tests that are done in the hospital. For example, in our training hospital at Kenyatta National Hospital, we receive almost 300 requests for total blood count and peripheral blood film daily, right? Because it has very, very many patients, and majority of these patients, the bulk of laboratory tests comprise the clinicians asking for a total blood count and peripheral blood film, all right? So these tests are usually baseline evaluation of a patient who may be having another disease, or it may be done even as part of diagnosis of a suspected hematological, and the doctor is looking for information to be able to make a diagnosis, allude to a diagnosis. And I have said almost every patient who seeks healthcare in any a higher level health facility that has a good laboratory is usually requested to have a total blood count and a peripheral blood film. So usually hematology labs are usually very busy because of this. All right, so let's look a little bit at the peripheral blood film. Excuse the typo error there. It says the peripheral blood film. There's an I between R and P, all right? So the peripheral blood film is just an examination of a patient's native blood, which is collected in an appropriate anticoagulant. in the wards. It's collected by various technologists or even doctors, or even some of you will be able to collect this sample when you come to the clinical areas. And what happens is that it's collected in an anticoagulant. The volumes are specified by the tube that is required, so that there's a proper proportion of the blood sample that is collected to the anticoagulant. And there are various anticoagulants that can be used, but the commonest that is used in the hematology is an anticoagulant called EDTA, that's the short form, or ethyl-diamine tetraacetic acid. Don't worry about that. You're going to be introduced to these anticoagulants in the practical class. And then the film is spread, and I said this is going to be done in a practical class that you're going to do. And when you come into the third year, you have a chance to learn how to spread it when you come in the smaller groups in the clerkships that you do throughout the year in third year. And then the peripheral blood film is stained using the Romanowski stains. Romanowski stains are various types. There are very many types of Romanowski stains. I don't know if you have been introduced to them in physiology, but when you come to the laboratory, you will see some of these stains. You have Leishman, you have Wrights, you have Jenners, you have May-Grunwald. There are very many types of Romanowski stains, and they all have basic hematological properties that we use so that the red cells and the white cells can stain and maintain their morphology, so we are able to tell changes in the morphology appearance of the red cell. All right. And I've just talked about the importance of the peripheral blood film. It's requested for various diseases. You'll find, for example, in liver disease, changes that may occur in the red cell morphology, and a patient who has liver disease, the doctor may ask for peripheral blood film examination. So usually a peripheral blood film may confirm or may suggest a possible diagnosis to the clinician. All right. So sometimes we're able to diagnose. Sometimes we may be able to allude to a possible diagnosis by just looking at the peripheral film, or give differentials that we are seeing this change here, and these are several causes of this change of the cell that is occurring, and that gives the clinician some information in terms of evaluation of the patient and making diagnosis. All right. So MBCHB2, are we together? You know, when you're giving a lecture, you're talking to a wall. Are we together? Can you hear me well?
Yes.
Thank you. Okay, so then we come to the peripheral blood film report. So as doctors, again, in various fields, you'll be receiving peripheral blood film reports, which are generated by expert morphologists, and those are the hematologists. So if you come to the laboratory at Kenyatta National Hospital, you will find many of us examining peripheral blood films, generating reports that are taken to the hospital, and they are patients that have requested them, and this helps the clinicians evaluate or manage or make diagnoses or manage their patients in whichever management they're going to do, right? So usually the report is a standard format report that describes the components of the peripheral blood film, of course, which are the cells and the various types of white cells. But for this lecture, we are only talking about red cells, because the lectures on white cells come after a set of lectures in red cells. So today we're just looking at changes in the red cell morphology. But when we generate the report, we look at everything and we generate this report. This report has a standard universal format. So whichever health facility or institution you'll practice all over the world, the format is the same. The report is the same. All right. So we report on what changes are seen in the red cell, what changes are seen in the white cells and what cells are seen in the platelets on the peripheral blood film. Okay, and usually when we are giving a report, because we give a conclusion to what we see, the examination and the report is guided by information that we already have. And what is this information? The information is given by the clinical information that comes from the requesting doctor. For example, a patient may come to the hospital and has complaints of abdominal swelling, for example, and vomiting, all right, and or may have yellow eyes, which is jaundice. So when the clinic is generating the request for a total blood count and a peripheral blood film, they will give that information, all right. A request form which may come either digitally or it may come as a hard copy that comes to the laboratory and says, this is X patient, he is 7 years old and came with abdominal swelling and jaundice. And then the request the total blood count and the peripheral blood film, and processes the parameters and makes a peripheral blood film, brings it to the hematologist or the morphologist, and then we report. And using the information that we have, the clinical information, and using all the total blood count, the red cell values and indices, we're able to generate a report on the red cells. That will help to further investigate the patient, or even we may be able to make a diagnosis based on these two examinations, all right? That is the value of the report. So if you go to the hospital, almost every inpatient in Kenyatta National Hospital will have a total blood count and a peripheral blood film report within their medical records. So I'm going to start now introducing some of the terms that we use to describe the red cells, and these are everyday terms that you will be using in your medical practice, that you will learn throughout your training, and even that you will use as practicing clinicians to describe your patient reports as you discuss them, and actually supposed to understand what these terms mean. So the first thing that we describe about red cells is if there is a variation in size. Remember, I said that the normal red cell is referred to as normocytic. So the variations in size can be either the red cell is smaller or the red cell is larger. And if the red cell is small, we call that microcytic, a microcytic red cell. All right, microcytic red cells. And needless to say, they are conditions that will give you microcytic red cells, clinical conditions or diseases that will give you microcytic red cells. All right, and when you look at the index that describes red cell size, which is the femtoliters, and we know the normal biological interval or reference range, which you were introduced to last week. We know for femtoliters, the normal reference range is 76 to 96 femtoliters. Other labs may quote something like 77 to 70 to 97, but it's usually in that general size, all right? So microcytic cells will have a femtoliter of less than 76 femtoliters, which means the cells are small, all right? And if the cell is large, we call that a macrocytic red cell, all right? A macrocytic red cells, and macrocytic red cells will have a mean cell volume which is greater than 96, 97 femtoliters. So we call that macrocytic red cells. Okay, so the term that we use to describe variation in size is called anisocytosis. So anisocytosis means variation in size. So if we're looking at a peripheral blood film and majority of the cells are small, we'll say red cell anisocytosis microcytes, right? We say that we are seeing microcytes. So variation in shape is called poikilocytosis. And there are many variations in shape. I'm going to show you some of them. I'm going to show you some of the photographs of the various variations in shapes. And one might say, why are we describing all those? And I'm saying that we describe this because we know certain disease conditions give certain changes in the red cells. And these changes, these changes, are we able to mute? Thank you. Class rep, are you able to mute everyone? Okay, so this changes characterize certain clinical conditions. So when we see microcytes, certain clinical conditions go through our minds. When we see macrocytes, certain clinical changes go through mind, because we have studied that, you know, that these changes will give you microcytic red cell changes, and that these changes that will give you macrocytic red cell changes. All right, and variation in shapes are many, and poikilocytes may occur in many types of diseases. Different types of poikilocytes or changes in shapes may occur in many diseases. So I gave an example of a sickle cell, for example. Sickle cell is a variation in shape, all right? So when we see sickle cells, we say it's poikilocytosis of sickle cells, all right? And remember, say sickle cells, it gives the clinician a message. This patient is having sickle cell disease, all right? Because there is probably no other condition in medicine that gives you sickle cells, and that they're easily seen on the peripheral blood film. And I'm going to give you a picture of those, and you'll be able to see them when you are doing your practical class. All right, then we describe the area of central pallor. And remember, I said that the normal red cell has the area of central pallor, the area that is not hemoglobinized, is usually just less than a third. All right, so a normal has just less than a third of its cell that doesn't have. This is on a 2-dimension. But remember, in a 3-dimension, it is usually the hollow or the biconcave shape that the red cell has. All right. So when the area of central pallor is less than a third, or just a third, we call that a normochromic cell, which means the red cell is normally hemoglobinized. When it is the area of central pallor is greater than a third, we call that a hypochromic red cell. And when the red cell is the hemoglobinization is greater than a third, and usually this the term hyperchromic refers to a certain cell which is called a spherocyte, where you're not able to see the area of central pallor. We say that the cell is hyperchromic. And you remember from your red cell indices, the parameter that measures the red cell hemoglobinization is the mean cell hemoglobin, the MCH. And remember, the MCH is described or expressed in picograms, PG, which is picograms. And I think you are told that this can be derived from a formula that involves the red cell and the amount of hemoglobin that is there. All right, so mean cell hemoglobin described by the MCH. Morphologically, we say the cell is normochromic. If it is normally hemoglobinized, it is hypochromic if the area of central pallor is big and poorly hemoglobinized, or hyperchromic if the area of central pallor is not there, and referring to a cell that may lose its central pallor, which is usually the spherocyte, and we call that hyperchromic. All right. Then we also describe inclusions. Of course, the most important inclusions are parasites. We do know that there are certain parasites that you're going to study when you do your microbiology, when you do your parasitology and your biology. You'll be told some of the intra-red cell cellular parasites. Of course, one of the commonest and an important infection here, which is an intracellular parasite, is the malaria parasite. So we are able to see if a patient has malaria parasites, we're able to see the malaria parasites, and we're able to make a diagnosis and tell the patient that your patient has malaria. And these parasites, sometimes we're even able to tell the species, for example, like you know that malaria has several species, and we're able to say whether it is falciparum or whether it is vivax. We're able to tell that because this parasites certain morphology within the red cells, all right? So there are many inclusions which occur in abnormal patient. Remember, as we said, a normal red cell does not have inclusion. It just has the hemoglobin, and the cell is nicely pink. It has nothing in it. And when you see inclusions, the inclusions can be either remnant nuclear material, they can be remnant iron that goes into the structure of hemoglobin. It can be abnormal hemoglobin aggregates that we see, and we are going to give examples of this, or there may be parasites, all right? So that is the way we report red cells. Those are the descriptive terms that we use to describe the morphological changes that occur for the red cell, all right? So variation in size, which we refer to as anisocytosis, variation in shape, which we've referred to as poikilocytes, and I'm going to give you examples of these. We also describe the degree of hemoglobinization, and we use the terms normochromic, hypochromic, and hyperchromic. And then, of course, if there are inclusions, we will say what types of inclusions are. And there are many types of hemoglobin inclusions. That the parasites, for example, there is iron, and we call those Pappenheimer bodies, and we could have the material remnants, which we call Howell-Jolly bodies. So you're going to be introduced into all these. And then when you do your disease condition, you will be, the changes that those disease conditions that give will be, you know, they'll tell you, for Jolly bodies are seen in patients who have poor functioning spleen, for example, hyposplenism, all right? And so when we see the Howell-Jolly bodies, which are nuclear material, we say that, you know, there is the spleen, for example, all right? So I'm just giving examples of some of the clinical relevance of these, all right? So that is your general format of the PBF report. When you become a doctor, and even when you're doing your training, looking at results for a peripheral blood film, that's the general format that the report takes, all right? For red cells. Remember, white cells and these platelets, which we're not dealing with today. We're just dealing with the red cells, okay? All right, so I've just put this for completion. We're not going to talk at all about the red cells. We're not talking about the platelets. This will come in subsequent lectures when you're doing leukocytes and when you're doing platelets. So just as a completion to tell you that a peripheral film format has a description of the red cells, has a description of the white cells, and has a description of the platelets. I'm not going to say any more about these slides because white cells and the platelets will be dealt with later. All right, so one may ask, how do these red cell abnormalities or morphological changes occur? You know, what all right, in these disease conditions, in these many conditions, what contributes to changes in this anisocytosis, in the poikilocytosis, in these inclusions? What brings about these changes, right? So these changes, as a result of the many disease conditions that occur in medicine, may occur because there is abnormal erythropoiesis. So the normal erythropoietic process in the marrow may be defective because of a disease condition, all right? And then you get the morphological changes, all right? For example, if you have a disease deficiency of iron, and you're going to, in your subsequent lectures, you're going to talk about causes of microtic red cells, causes of macrocytic red cells. You're going to go through that. So, for example, if you have a deficiency of iron, and you know the value of iron in hemoglobin synthesis, you know that iron is vital in the formation of red cell of hemoglobin. It's a central mineral that is required in hemoglobin in hemoglobin metabolism or hemoglobin synthesis. All right. So if you lack iron, then you'll have abnormal erythropoiesis. The cells do not have enough hemoglobin. All right. So abnormal erythropoiesis can give rise to red cell morphological changes. And if the cell is not well hemoglobinized because you don't have iron, then you're going to get hypochromic red cells because the cells are poorly hemoglobinized. So that's an example of abnormal erythropoiesis. All right. The second one can be, again, which ties up to the abnormal erythropoiesis, if you have inadequate hemoglobin formation, which gives you hypochromia. All right. So abnormal erythropoiesis may be anything to do with, let's say, deficiency of iron, deficiency of red cell folate, deficiency of the proteins that are required to undertake erythropoiesis, abnormality in the regulation of erythropoiesis. For example, we know that erythropoiesis is regulated by the various types of cytokines and hematology growth factors. So if there is a problem in that regulation, then you're going to get abnormal erythropoiesis. If you have deficiencies in iron or folate or vitamin B12 or the other proteins that make up hemoglobin, you're going to have inadequate hemoglobin formation, and you will have red cell morphological changes. All right. So the third cause of morphological changes, if there may occur if there is damage or if there are changes that affect the cells after it leaves the bone marrow. You can have a very red cell leaving the bone marrow, but this red cell may have damage to it in peripheral circulation, in the spleen, for example, that will cause it to get damaged, or the membrane structure may change, for example, or the membrane composition may change, and the red cell changes its shape, and then you get the various poikilocytes that we're going to see. All right. One of the organs that gives a lot of morphological changes on the red cell is the spleen. Remember, we are going to study the function of the spleen. I don't know whether you've already done it in physiology, but the spleen usually alters or can alter red cell changes. For example, the spleen may remove abnormal inclusions within the red cell, like Howell-Jody bodies sometimes may be removed by the spleen. Sometimes, if the cells get stressed while circulating through the spleen, a red cell change may occur, like part of its membrane may be removed, for example. I'm just giving examples, and then you get the cell sphering, for example, and the cell becomes a sphere, and that's a poikilocyte change, right? So splenic function may change or give morphological changes to the red cell. All right. The other morphological changes that may occur in circulation on the red cell are results of attempts of bone marrow to compensate for an anemia, for example. For example, let's say if you look at the homeostasis, when a patient has anemia, and anemia is a low hemoglobin, the bone marrow, if it is functioning normally, usually will compensate by increasing erythropoietin levels. You know, erythropoietin is what drives red cell erythropoiesis, and then increases the red cell production in an attempt to overcome the reduction in hemoglobin. And by doing this, sometimes it may extrude red cells that are not fully mature into peripheral circulation. And then we detect these abnormal cells or immature cells like reticulocytes or polychromatic cells, for example, or sometimes it may even extrude cells that still have a nucleus in them. So we see nucleated red cells in peripheral circulation, and this may be an attempt by the bone marrow to compensate for an anemia, for example, and this produces red cell morphological changes. So in essence, these 5 points are what brings about those morphological changes that occur in peripheral circulation, and we are able to detect them and allude to a disease condition. So these are the mechanisms that may bring about abnormalities of red cell morphology. Okay, so I hope that was clear. So I think I've talked about variation in size. I've talked about the macrocytes, so I'm not going to go over it again. And we just said that a macrocyte is a large cell that has a high MCV greater than 97. And we have microcytes, which are usually less than 6 micrometers in diameter, and the MCV is usually less than 75 femtoliters. All right, and usually you find that microcytic cells usually have areas, an increased area of central pallor, and may occur in certain conditions. So just to introduce some of these conditions, macrocytes are usually seen in conditions like megaloblastic anemia. Megaloblastic anemia is a deficiency of vitamin B12 or folate, all right? And we know that when you have vitamin B12 deficiency or folate deficiency, you get an anemia which is called a megaloblastic anemia. You're going to have a whole lecture on megaloblastic anemia, and this gives you macrocytes. So what I'm saying is that when we see macrocytes, some of the differentials that come in our minds is that could this patient be having a vitamin B12 or folate deficiency? But do know that macrocytes can also occur in liver disease. They can also occur in other conditions like aplastic anemia. They can occur also in leukemias, for example, all right? So when we see macrocytes, we have all those differentials that come in our mind, all right? And then I've put an example there that sometimes the microcytes may be oval in shape, and we know that megaloblastic anemia usually gives you oval macrocytes, all right? In liver disease, they're usually round. So when we are looking at the variation in size and we see large cells, we see, is it large and oval? Then we may think, oh, this patient has megaloblastic anemia, all right? Is it large and round? Then we think, could it be liver disease? Could it be aplastic anemia? Could it be a leukemia, for example? Could it be a myelodysplastic syndrome? So many causes of macrocytes. I've just given an example there. Then we have microcytes. Microcytes are small cells, usually poorly hemoglobinized. The MCV is usually low, the MCH is usually low, less than 25, 26 picograms. So you get picograms of like 19. And these are usually seen in iron deficiency anemia because of poor hemoglobin formation. The cells become small and they're poorly hemoglobinized. And we see this in iron deficiency. You're going to have a whole lecture on iron deficiency because it's the commonest cause of anemia worldwide in certain groups, especially children and women of reproductive age group. So iron deficiency anemia is very important in clinical practice because many patients have this condition. And it gives you small, poorly hemoglobinized cells that have a low MCV. And then another condition that gives you microcytes is thalassemias. Thalassemias are hemoglobinopathies, right? And you're going to have a lecture on hemoglobinopathies. So all these conditions form some of the topics that you will handle in the third year. They'll be introduced in second year, and then you'll handle them in more detail in the third year. Okay, so that's variation in size. Macrocytes, microcytes, right? So I don't know whether you can see this properly, but this is a micro photograph that shows you small, poorly hemoglobinized cells. You can see these cells are small. Area of central pallor is very big. Majority of them don't have any hemoglobin at all and are very pale. All right. I hope you're able to see that. So this is another picture of a microcytic hypochromic picture. Small cells, pale, with an increase of central pallor. You have some abnormal shapes there, all right? So this is a picture that we would see if a patient has iron deficiency. And we see this a lot. Every day, we have many patients being investigated for iron deficiency anemia, and we see this a lot in the laboratory when we stain the peripheral blood films, right? That's a picture of a microcytic hypochromic cells, right? Small, poorly hemoglobinized cells. All right, these are large cells. You can see the cells are large. They're not all large, but we do see variation in size. They're oval in shape. All right, this may not be a very good photomicrograph. They're better seen at under the microscope, but this is a large cell, right? So this again is large cell. This is a neutrophil, which is abnormal. So you see large cells, all right? And what I should have here is a small mature lymphocytes that we can use to compare with the size of this red cell, all right? So this is a large cell, this is a large cell, this is a large cell, okay? So these are macrocytes, all right? So those are examples of variation in size: anisocytosis, microcytes, macrocytes, okay? Clear about that? Any questions can be put into the chat, handle them at the end, okay? So we go to poikilocytes. So red cell defects, poikilocytes, variation in shape of red cells. These are very many, all right? There are very many. I'm just going to introduce them. Don't worry too much about them right now because you will handle them again when you are studying various conditions. And again, when you come into third year in your flagships, as you do your systemic hematology lectures, when you're handling specific disease conditions, you're also going to handle them, all right? So I'm just going to introduce these terms so that you can see these variations and these defects, and also just mention some of the conditions that these variations in shapes occur. For third year, for second year right now, if you look at your objectives, you should be able to at least name some of these poikilocytes and be able to give examples of in which these different poikilocytes occur. All right. So the first variation is an acanthocyte, and I'm going to show you a picture of this. And these are the other names that are given to acanthocytes. Sometimes they're called spur cells. So in your reading, you may get the acanthocytes being referred to spur cells. All right, or sometimes they're referred to as thorn cells. You will see they look like a thorn, or sometimes they're referred to as spiculated red cells. So these are red cells that develop spicules or spikes, and they usually have 5 to 10 spicules, all right? And they're usually seen in these conditions: alcoholic liver disease. They may be seen in a patient who's just had their spleen removed out, that is post-splenectomy, or they may be seen in lipid metabolic disorders like abetalipoproteinemia. Usually occur because there's changes in the cholesterol and non-cholesterol component of the red cell membrane, and the red cell becomes spiculated, and we call that an acanthocyte. Then there is a bite cell, which may occur because of repeating action of the spleen. So the spleen may remove a little bit of the red cell, all right? And the red cell forms like a cup-like, where the bit has been removed and it mends itself. So we call that a bite cell. And bite cells are seen in enzyme deficiencies like G6PD deficiency. G6PD deficiency gives you a hemolytic anemia. It's going to be one of the topics that you will handle when you're doing hemolytic anemias in the third year. Again, bite cells may be seen as an effect of various drugs like dapsone. Dapsone is a drug that is used in treatment of leprosy, and it can give you bite cells, all right? So a bite cell is a poikilocyte, and the significance when you see bite cell, we say, oh, could this be a G6PD deficiency, or could this patient be on drugs like dapsone, all right? And I'm going to show you pictures. So these are acanthocytes. The cells have these spicules, all right? They have these spicules on them, and we said it's because of change in the cell membrane composition of the red cell, and the membrane becomes abnormal and forms these spicules. So these are acanthocytes or spur cells, all right? These are spur cells, okay? This is an acanthocyte also. You can see these spicules that have pointed an arrow there, all right? So we also have echinocytes, a Burr cell, and this one has more spicules. The other one has, this one has about 10 to 30, and we echinocytes, or the other word for echinocytes are called Burr cells, and Burr can be seen in many conditions, like in uremia, where patients have kidney failure and they have very high urea levels in circulation. They may be seen in enzyme deficiencies like pyruvate kinase deficiency. They may be seen in peptic ulcer diseases, or, for example, patients who have cancers of the stomach. Echinocytes may appear in circulation, all right? So when you see echinocytes, those are the causes or differential causes that come in our minds, all right? Then we have other poikilocytes, which are also, we call spiculated red cells, like helmets, that lose part of its membrane as it, for example, in pathological conditions where you get fibrin strands being formed in circulation, in arterioles, all right? And we call that microangiopathy, when the red cell is damaged. So we say that the red cell has been damaged within the arterioles, so we call that microangiopathic hemolysis, all right? And you're going to go through conditions that will give you microangiopathic hemolysis. For example, DIC, you come across acute kidney failure may also give you microangiopathy, and you see helmet cells in peripheral circulation. Right? So helmet cells usually have two sharp edges or three pointed edges, and it looks like a helmet. And I'm going to show you examples of that. All right. And they're called helmet cells. So these are echinocytes. You can see they have very many spikes, all right? The other one, the acanthocytes had 5 to 10. This one has many, many spikes on the red cell, all right? More than 10 echinocytes, all right? And then the echinocytes, they have these spikes, many spikes on the red cell. And we've seen the conditions that we can see echinocytes in, all right? Then we have helmet cells, and helmet cells have this normal spicules, and you can see it's like a helmet, right? So that's why they're called helmet cells, and are usually seen in microangiopathy, where you have red cells being damaged in circulation because of formation of microclots, fibrin strands in various conditions, all right? So helmet cells, another poikilocytes, all right? So we also have a rouleau, where you get aggregates of erythrocytes, and they appear like stacks of coins, and we see this in various conditions, like in chronic infections, where you have production of immunoglobulins, and you have high levels of circulating immunoglobulins, like in chronic infections, HIV. Usually we see this rouleau formation of erythrocytes. We also see them in malignancies that produce paraproteinemias. We call this multiple myeloma, and you're going to have when you come, and we're doing hematological malignancies in third year and in fourth year, when you're doing cancers, you'd be introduced and told what multiple myeloma is. You'll have a lecture on multiple myeloma, and one of the investigations they do in multiple myeloma is a peripheral blood film, and usually we see this rouleau formation. Okay, so then there is schistocytes that we also described, and helmet cells also fall under the group of schistocytes. So schistocytes are just injured red cells. They're fragmented. They're just fragments of red cells, and they occur in many conditions. We see them in patients with burns, and also in microangiopathic hemolysis, where we'll see helmets, and we also see fragmented red cells. We call them schistocytes. And I'm going to give you an example of schistocytes. So this is rouleau, where they stack on a peripheral blood film. Instead of being single cells, they sort of onto each other. And we see them in conditions where there's high protein levels in circulation, say multiple myeloma, or in hypergammaglobulinemias, all right? That's rouleau, all right? These are fragments. You can see fragmented red cells, all sorts of strange shapes of red cells, looking like they've been fragmented. They have these spicules, and these are the schistocytes. This is a neutrophil, all right? So these are schistocytes, these fragmented cells, all right? Fragments again, you can see fragmented red cells, all right? These, you can see some normal looking red cells, and then you see these fragments, all right? So fragments again, helmets, all right? Also fragments, we say these are various fragmented red cells, and we call this schistocytes, all right? And these are injured red cells in circulation, all right? Okay, so to sickle cell, all right? Remember sickle cell, another name for sickle cell that you will see written in your books is drepanocytes, all right? So drepanocytes, usually thin, elongated erythrocytes with pointed edges. They may take a shape of an L or an S or a V or an arc. I'll show you some of them. And they're usually seen in the hemoglobinopathy, which is sickle cell disease. Sickle cell disease or sickle cell anemia is important disease here in Kenya because it affects a lot of our population. And remember, it's a genetic disease, so we usually see it in certain ethnic groups, usually from the Coast Province, Kisii, and of course Nyanza and Western Province. That's where you see mainly that genetic disease of sickle cell. So it's an important disease. You're going to study it in detail in third year and in fourth year when you do your pediatrics. All right, you're going to see lots of children with sickle cell. And at Kenyatta National Hospital, we have a special clinic just for children with sickle cell, these patients, right, every Monday morning. And you'll have to attend that clinic, I think, in the fourth year. All right. Then you have spherocytes. Spherocytes are, we said, are cells that have lost the area of central color. Usually, the red cell looking like a donut shape. It takes a spherical, dense appearance with no area of central pallor, and it usually looks very deeply stained, and it can occur because of abnormalities in the composition of the protein components of the red cell membrane. And usually the components that are affected is the spectrin protein, which is the majority compound that makes up the red cell membrane. So if you have deficiencies in spectrin, then you get a spherocyte. So it can occur genetic disorder, which is hereditary spherocytosis, is inherited where there is a deficiency of the spectrin protein. To study this condition again, it can occur in other acquired conditions, like in certain hemolytic anemias, especially immune-mediated hemolytic anemias. It can occur in burns also. Spherocytes can occur in burns. They can occur in snake venom bites, where you get injury to the red cells because of various chemicals like snake venom and other chemical injuries. And also, like I said, in immune diseases, you can see spherocytes. So spherocytes, I'm going to show you a picture of that, are cells that don't have an area of central pallor. So they occur like spheres. On a 2-dimension, they look like cells that don't have an area of central pallor. In a 3-dimension, it's like a spherical, it's like a ball, right? So as opposed to the normal biconcave, it occurs like a sphere, like a ball, right? So these are sickle cells, all right? Very recognized, all right? Sickle cells are there. A good prototype one, an elongated cell with a sharp edge. And this occurs because of hemoglobin S, which is an abnormal hemoglobin due to substitution of different proteins, or rather amino acids, in the hemoglobin chain. You're going to go through the hemoglobinopathies, right? So sickle cells, you can see sickle cells there, all right? These elongated cells. This is a Howell Jolly body. So when you come to clerkship, you're going to do sickling test, where you introduce a certain oxidative agent to wet a wet blood sample, and if the cells have the abnormal sickle hemoglobin, they form these various shapes. All right, so they form these funny shapes, and it's a screening test that we use to detect whether a patient has sickle cell or not. It's a simple test, and you will do it when you come to the clerkships. I don't know whether they introduce this to you in physiology. So this is a sickling test preparation on a wet smear, and you look at it under a microscope and see how the red cell changes shapes when there is the sickled hemoglobin. Okay. B2, are we still together? Hello? Hello, class rep?
Yes, madam, we're still together. I muted everyone, that's why they can't answer you.
Okay, you've muted everybody. Very good. Yeah, because they were making noise. But you have to keep on giving me this feedback that we are together. And of course, put all the questions on the chats. Okay, so as we continue, I don't know why my cursor is not moving. Yeah, okay. So these are spherocytes, all right? Okay, you can see there's no area of central pallor. It's a bit faint, but you can see there's no area of central pallor. All right, these are spherocytes, very good spherocytes. The area of central pallor is gone. There's all this very dense staining of the red cells, and we call those spherocytes. And I've given some disease processes where you may see spherocytes, autoimmune hemolysis, hereditary membrane abnormalities. You may see these spherocytes. All right, chemical snake venoms may give you this. All right, so this is a rare membrane deficiency, which we call stomatocytes, and the area of central pallor occurs like a slit, and which looks like a mouth. That's why it's called stoma. And we usually see this in membrane disorders like hereditary, that are genetic, like hereditary stomatocytosis. Is rare, all right, and they're not very common, but they can also be seen in alcoholism. So hereditary stomatocytosis is rare membrane disorder, but because alcoholism is common, liver disease, we see a lot of liver cirrhosis, you may see stomatocytes in these conditions, all right? So these are some of the disorders where we may see stomatocytes. And that's a target cell also. Target cells, we see them, it's a cell that has where you get an area of hemoglobinization, an area of central pallor, and then a point, a hemoglobinization again within the center of the cell. I'm going to show you a picture. We call that a target cell. And we see target cells in hemoglobinopathies, the sick cells, hemoglobin C, hemoglobin D, all those are hemoglobinopathies. In thalassemias, because thalassemias are also hemoglobinopathies, you see target cells. They're also seen in liver disease, and they can also be seen in patients who have had their spleen removed. And target cells occur again because of changes in the cholesterol and lipid levels with red cell membrane, right? And they're seen in those diseases, all right? So this is an example of a stomatocyte, all right, where you have the area of central pallor occurring like a slit. Instead of it being round, it's a slit in the middle of the red cell, and it looks like a stoma. So we call that stomatocytes. These are target cells where you get an area of hemoglobinization that is surrounded by a pale area, and then another area of hemoglobinization. So these cells look like there's a target at the center, all right, of the cell, all right? Sorry, so this looks like a target. So these are called target cells, and we say they're seen in hemoglobinopathies, and you can see them also in liver disease. Okay, so many examples of poikilocytes, and you can see the clinical relevance, because when we see them, it makes us think of differential diagnoses or different causes of what could be going on within the patient, all right? So when we see target cells, we say could this patient having a hemoglobinopathy, or could the patient be having a liver disease, for example? And then we do other tests that, will let us know, is this hemoglobinopathy or is this a liver disease, all right? So these are teardrops, and they look like a tear. They look like a tear that's just about to drop. And another name of teardrops is called dacrocytes, all right? So you can see these teardrops, okay? And usually teardrops are seen in several conditions, right? I've put a list of conditions there. They may also be seen in megaloblastic anemia. They may be seen in bone marrow infiltrative disorders like myelofibrosis, and they may be seen in many other cancer conditions, which we call clonal disorders in hematology, like myelodysplasia, right? So when we see teardrops, these cells that look like tears, right? Like this one, big one here, all right? These ones here, think of these various conditions, right? So the message here is that these retinal morphological changes are ubiquitous in that you see them in many conditions. So when you see them, then you may give a differential diagnosis. Sometimes the clinician may have given you an example that this patient, like for example, if a patient has target cells and they've got jaundice, all right, and we know jaundice can occur in liver disease, so you can narrow down and say this is likely due to the liver disease, but we know that target cells can be seen in many other conditions, right? So you can see that the poikilocytes have clinical relevance in many diseases, and can allude to a differential diagnosis or can assist the way we investigate patients further, make a diagnosis. All right, so those are teardrops. All right, these are elliptocytes, and we see elliptocytes in membrane disorders like hereditary elliptocytosis. The cells are elongated and they have this elliptocytoid shape. All right, these are elliptocytes, okay? So they look a little bit like cigarettes or sausages, and we can see those under the microscope, and we say these are elliptocytoid poikilocytes, all right? And so these elliptocytes are usually seen in membrane disorders like hereditary elliptocytosis, all right? Okay, so those are examples of the poikilocytes. I have not handled all of them. I've just handled the major ones. You'll be introduced in clerkships, and again, as you describe the various disease conditions, as you study the various disease conditions, and you're looking at peripheral film findings, the various poikilocytes that occur in those diseases will be described. All right. So we've talked about now variation in size, and we've talked about variation in shape. All right. So we've seen the various shapes and variation in size. We said it's either normocytic, microcytic, or macrocytic. All right. So we can also have variation in hemoglobinization, and this usually occurs as a variation in the color or intensity of the color that the red cells take when they are stained with the Romanowsky stains. All right. So this is usually due to variation in color of the red cell due to variations in the degree of hemoglobin or an equalization in the hemoglobin content of the red cell. All right. So cells that don't have enough hemoglobin or are poorly hemoglobinized will stain. We'll just have a thin rim of staining. They'll be pale. They'll not take up the stain, and we call that hypochromia. So hypochromia, as I said, is increase in the area of central pallor, and I think I have explained that enough. All right. And hyperchromia is the cells that lack the area of central pallor. And remember, I showed you a macrocyte and I showed you a spherocyte, and those cells don't have an area of central pallor. So variations in hemoglobinization that correspond to the degree of stain that the cells take is called anisochromia. All right. So when we see hypochromia, we say there is anisochromia and the cells are hypochromic. all right? There's anisochromia and the cells are hyperchromic, all right? The third variation in color or in the third variation in anisochromia is polychromasia. So polychromasia is where the red cell takes a bluish tint under the microscope, because we know that the under a lot of the Romanowski stains give you sort of like a pinkish, purplish staining of the red cell. They're nicely pinkish, pinkish red, or or deep pink staining, as we have seen. So in polychromasia, the red cells take up a bluish tint, and this occurs because of remnant RNA material that is contained in the red cell that takes up the stain and gives the red cell this bluish tint. And usually under the Romanowski stains, the cells will be bluish. And then we say that the cells are polychromatic. So these cells that usually have remnants of RNA material are usually immature cells that have been released into circulation. And these cells, are usually reticulocytes, because that is the definition of a reticulocyte, which is the stage, the maturation stage before or below the reticulocyte, or rather below the erythrocyte, the mature red cell as we know it. And this cell usually has remnant RNA material, ribonucleic acid material, and we know that these cells sometimes they form a small percentage in normal circulation. For example, if we take your blood, for example, a few of cells circulate as reticulocyte, and they will mature in 2 to 3 or 5 days into the red cells that we know, all right? But in certain conditions, these reticulocytes may increase, or these polychromatic cells may increase in circulation because of hemolysis, because of hemorrhage, and this is usually an attempt of the bone marrow to increase the red cells in circulation to compensate for the red cells that are being destroyed in hemolysis, for example, or the red cells that are being lost in bleeding or hemorrhage. And then again, in treatment of, let's say, iron deficiency anemia, when you give patients iron as part of the treatment, then you get them forming appearances of reticulocytes or polychromatic cells in peripheral circulation. All right, and we know that these reticulocytes in aplastic anemia, where the red cell is hypoplastic, it doesn't have enough red cell precursors, for example, then you get a reduced reticulocyte. All right, so polychromasia, bluish staining of the red cell because of presence of reticulin material or RNA material. All right. And these cells are usually young cells that are in peripheral circulation. Can be normal, a small percentage, about 2% of red cells circulate as reticulocytes, but they can be increased even to 4, 5, 6, 7, 10% or 11% in certain disease conditions, all right? Where now you get a lot of these polychromatic cells circulating. All right, so this is a polychromatic cell, right? That bluish cell there is a polychromatic cell. It takes this bluish tint. So you can see normal staining cells, and then there's this polychromatic cells, right? Then there are other inclusions that I'm going to introduce, like basophilic stippling. Basophilic stippling, you see it in conditions where you have abnormal erythropoiesis, where you get inclusions within the red cell that may be aggregates of hemoglobin material, for example, aggregates of iron material, for example, may occur as stippling. So you see these dots, okay? You have to be a very keen morphologist to see them, and we call that basophilic stippling. All right, so the red cells here are normal, but you can see this, and this one have this stippling. All right, so this is also basophilic stippling. You usually see it in injury to red cells, either chemical injury to red cells that may give you abnormal red cell metabolism, and you get that stippling. Okay, so basophilic stippling, all right, and they're usually precipitates of protein material, ribosomes, heme material that are usually of varying size, and they appear bluish with with Romanowski stain, like Wright stain, and are usually seen in chemical injury, lead, or for example, heavy metal injury or poisoning, like lead poisoning, for example. We see basophilic stippling. You may see them in several other nutrition deficiencies, vitamin E deficiency. You may see basophilic stippling. And then, of course, we said also drug injury, especially like cytotoxic drugs that are used in cancer therapy, may produce precipitation of ribosomal materials, protein materials that will occur as basophilic stippling. All right. Carbot rings are not very rare. Quite rare, sorry, they're quite rare. We don't see them very often. Can be seen in megaloblastic anemia. They're usually seen, you have to stain, sometimes use special stains like the Wright stain to see them, and they're usually seen as dark blue rings. They're not very commonly seen, but can be seen in severe vitamin B12 or folate deficiency, which is megaloblastic anemia. You can see carbot rings. All right. Then Haynes bodies are usually seen in hemoglobinopathies, or are seen after use of certain drugs that injure the red cell, and they form oxidative degeneration of the hemoglobin. All right. So Haynes bodies are also inclusions. So we are on inclusions now. So inclusions, we have basophilic stippling, we have Haynes bodies, we have carbot rings that are seen in various conditions. All right. So all these will be emphasized again in the clerkships. Okay. Howell-Jolly bodies, like I said, may occur in where you have nuclear fragments that are left within the cell, because remember, the red cell extrudes its nucleus, and some of the nuclear material may be abnormally left within the red cell, and they circulate within the red cell as an inclusion, which is called Howell-Jolly bodies. So when we see Howell-Jolly bodies, we know there are DNA nuclear remnants within the red cell. All right, and Howell-Jolly bodies are usually removed by the spleen, and then the red cell becomes, normal. So that patients who don't have spleens usually have a lot of Howell-Jolly bodies because there's no spleen to remove them. And when we see them, we allude to poor splenic function or patients who have had their spleen removed. All right, so these are Howell-Jolly bodies. You can see this nice purple body that usually occurs at the edge of the red cell, and are easily seen with Romanowski stains. In this slide, you can also see target cells. You can also recognize these target cells. All right, and you can see a Howell-Jolly body here. All right, so these are Howell-Jolly bodies. Okay, so a demonstration of a Howell-Jolly body. So we can also see iron relevance. Of course, you know the use of iron in the red cell is for heme synthesis, and sometimes you can iron granules precipitating and forming inclusions within the red cell, and they usually occur in the periphery of the red cell membrane, just like Howell-Jolly bodies, and we call them siderotic granules or Pappenheimer bodies. All right. And if you want to see them properly, usually we stain them using the Wright stain. The Wright stain is one of the Romanowski stains. Okay, so Pappenheimer bodies. These are the Pappenheimer bodies. All right, so one should be able to differentiate from Howell-Jolly bodies. Pappenheimer bodies can be several. in one cell. Howell Jolly bodies are usually singular. All right. So when a mature red cell has any Pappenheimer bodies, we call it a siderocyte. All right, siderocytes. They're demonstrated well using Prussian blue stains. All right, so I think the last poikilocyte, or the last inclusion is the malaria parasite. And we know that, as I said, malaria is an important disease here. And if you come to the hematology department, there are many peripheral blood films that we stain every day looking for malaria parasites for patients who have come into the accident emergency, children that may be suffering from malaria, and the doctors ask for peripheral blood smears for malaria examination, and we do that out. So many slides are usually stained. Looking for malaria parasites is peripheral blood film is the gold standard for looking for malaria parasites. But in practice now, we have many other methods of detecting malaria parasites. You have some automated methods that are used to detect malaria parasites. For example, the QBC, we have the Parasite F machines that are automated for looking at malaria parasites, but the peripheral blood film remains standard. So usually when a Parasite F, which is an automated method, is positive, we prepare a slide because it enables us to tell the species of the malaria parasite that the patient is suffering from. Remember, malaria has 5 species, all right? You'll be introduced to them when you do your parasitology, or some of you may know them, the falciparams, the vivax, the knoletes, and all that, okay? So these are gametocytes that we can see. Very heavy malaria infestation, a very easy diagnosis to make. All we do is take a peripheral blood film, we dry it up, we stain it, and we're able to see these parasites. And we're able to make a diagnosis in 20 minutes and make a report to the doctor. Okay, so this is a gametocytes. All right, so that's the end of the presentation. I don't know whether there are any questions in the chat. All right. Somebody's asking whether you're going to have a break. No, you're not going to have a break. We finished. You can have a break now. I was supposed to go up to 11, correct, class rep?
Yes, madam.
Okay. So somebody got tired and wants a break, but we are finished. Any other? Okay. I don't know, those are, okay, I'll just start from the beginning. So the beginning, there is recording, which has been done. That has been done, class rep?
Yes, madam, it's been recorded.
Okay, so everybody will have an access to the recording. So what is the significance of that area of pallor? I think this was explained, right? The area of pallor is a two-dimensional appearance of the red cell on the slide, because when we do the slide, it's two-dimensional. But you remember the shape of the red cell is a biconcave shape. So it's that hollow in the biconcave shape of the red cell that appears as an area of central pallor. So K, I don't know who K is. I hope that answers your question. All right. You can go and look at pictures in your books of red cells in 3-dimension and also in 2-dimension. All right. So the biconcave shape is what confers that area of pallor, and it's spelled P-double-L-O-R, not the way you have spelled it. The way you have spelled it is actually a room in a house. That's what it's the way you have spelled it. All right. All right. So how do you differentiate between echinocytes and acanthocytes under the microscope? And this was very clear. We said that one has 5 to 10 spikes, the other has more than 10 spikes. All right. So acanthocytes has 5 to 10 spikes. Echinocytes has, more than 10 spikes. And fragments too, how do you differentiate them? We can see them. All right. We can see the fragment, the the fragmented red cells under the microscope. It's very easy. It's visual, all right? You see a fragmented shape and you can recognize it, all right? So once you've seen many, all right, those of you who will study postgraduate hematology, you will be able to see the fragments and be able to differentiate them, all right? Obviously, we do not expect you to differentiate them right now because it's a competence that you have to develop, all right? By reading, by looking at many slides, and you develop that competence, right? So Julie, I hope that answers your question. I don't know, Judy has said something to do with yes. Oh, I think maybe I was asking whether you can hear me. Does anyone remember what the rule of formation done last year in the lab was related to? Okay, I don't know. That's between the two of you, between you guys. I don't remember that. I don't understand the question either. Does anyone remember what the rule of formation done last year in the lab was related to? Because it wasn't testing any pathology. Okay, I don't know. Okay, some joke there. Physiology.
Hello.
Okay, so Rulo can mimic agglutination? That's a good question. Harry, Rulo can mimic agglutination. So agglutination looks different under the microscope. Agglutination is when groups of cells clump together in a haphazard manner. Rulo is organized. It looks like a stack of coins, all right? So, and we know that when we have a rouleau and agglutination, if you have a wet slide that has rouleau and a wet slide that or blood that has agglutination, if you add normal saline to agglutination, the cells tend to disperse, but rouleau will be maintained. So that's how we differentiate it. But again, under a competent eye, it's very easy to differentiate rouleau and agglutination. Agglutination is a disorganized clump of red cells, all right? But agglutination is it's very neat. It looks like cells, the way you put a stack of coins together and then tip them, all right? So under the microscope, it's quite easy to differentiate, all right? Okay. Is there diseases that all cells usually deformed or fused so that a diagnosis is made? These diseases, are all the cells usually deformed or few are? Okay. So again, this is a competency that a morphologist has to acquire, all right? And there is a way, an objective way of determining whether the changes that we see on a peripheral blood film are significant in a disease. So in most diseases that are established, morphological changes are significant enough for the morphologist to detect. For example, in sickle cells, all right, majority, if we see like 50% or even 20% of the cells are sickled, all right, that's sickle cell disease. So there's an objective way of assessing the morphological changes that we see. So you might ask, if I just see one cell or two cells, all right, or three cells that are acanthocytes, for example, can I say there's an acanthocytosis here, all right? So when you're studying morphology, is usually a postgraduate competence that is taught for people to become hematologists and morphologists. There's an objective formula that we use to decide whether the changes are significant or relevant. There's some changes that, for example, if we see even 2 malaria parasites, that's significant. We can't ignore that. That is a parasite in your blood, so we have to report that. But if we see one target cell, for example, in a whole slide, that's not significant, all right? So again, these are competencies that are saying are, there are objective ways and objective formulae and ways in which we decide whether this is a significant for a disease or not, right? So I hope that answers Kevin's question, right? Another question, why don't we classify all forms of poikilocytes? Sorry?
We are supposed to be in another lecture right now.
Oh, sorry. So you have internal medicine, right? So what I'll do is I'll respond to the questions. If they're sent to me, I can respond them on email, right? So we can end lecture now so that you can go for your other class. Okay, thank you very much.
Yes, thank you.
All right.